When I was a medical student, I hated psychiatry. I didn't see the relevance of it.
I remember it being an easier subject at medical school, which I was quite grateful for, and had less reading to do. I always thought medicine was about surgery and A&E.
I felt unsure because the patients generally don't have physical symptoms, and so it only became apparent from what they said and how they described their feelings that they had pathology.
The World Health Organization defines health as having mental, physical and social well-being. It's not just about having physical well-being, it's about having every element in place.
The proportion of people who suffer from depression is around 10%. So people coming through to see me in my practice, it would be 1/10 of the people coming through have overt depression, and most certainly coming to see an orthopedic surgeon to have an operation, the majority, if not all of the patients are filled with some aspect of anxiety.
Psychiatry features in everyone's profession, whether you are a paediatrician, a gynecologist, obstetrician, gynecologist, general practitioner. People suffer with depression on the wards all the time because they're sick, they can't sleep. So it's really important that you've had some experience in it, even if you don't like it.
There's a 20-fold increase in the incidence of mental illness around childbirth. So if you look at a graph, it runs very smoothly and low until the first pregnancy, and then 20-fold increase in the incidence of first presentation of mental illness.
My patients have chronic abdominal symptoms that can influence their personality, their character, can increase the risk for these patients to develop psychomorbidity like depression or anxiety. If we don't address those symptoms, it's extremely difficult to manage these patients satisfactorily. As I always say, I don't treat bellies, I treat patients.
I counted my cases this afternoon and there was at least 60% were psychiatric or psychosocial. There's been some really interesting work done by someone called Goldberg who showed that there is a 1 in 3 prevalence of psychiatric morbidity in the community. Of that, only about 1 in 5 go to a GP and have detected or disorder detected. Of those, only 1 in 10 get referred to specialist psychiatry, and then the figures get really small. 6 in 1,000 of those are admitted for psychotic illness. So the level of psychiatric morbidity in the community is huge.
They're coming in to have a procedure which is quite significant in my case, a total joint replacement or a revision of that total joint replacement. They are fearful of that operation. They have concerns about whether they will suffer complications. They have concerns about how long the implant will last. So if you're not cognizant of those worries and concerns of your patient, you will make a pretty poor orthopedic surgeon.
And then of course there's puerperal psychosis, and the point about that is a dramatic onset with a sudden deterioration. We see it usually between 7 and 14 days. So a lot of these women are at home, okay? But that is the one that is linked with a significant risk of maternal death, by suicide, infanticide. Okay, the approach to the care of these women cannot be one specialist. So it's our job to detect and to pre-plan and to put in place support for that woman when she's at home.
So I've tried to deal with patients in a different way from what I perhaps used to before. I tried to be more sympathetic, to develop more rapport with patients, to try and calm them down, make them feel a little bit more comfortable in an environment which is stressful for anyone, but particularly stressful for patients who have anxiety disorders anyway. So I've learned to develop ways of not just giving them 2 or 4 milligrams of midazolam, but rather interacting with them and trying to pacify them a little bit that way.
And actually recognizing the fears and anxiety in people is really important in the reducing complications, improving rehabilitation in those type of patients. If you manage the patient before the operation properly, change the anxiety factor, you can improve the rehabilitation and outcome. And there's a big situation in all surgery where there is definitely post-operative reaction, but also there is significant depression when they go home, when they're not coping or managing, which is also again missed.
I think physicians are at risk of dismissing erratic behaviour, aloofness, an uncooperative nature. We are at risk of dismissing all that as mental illness. And certainly I know many times in my practice we have sometimes missed serious organic pathology by just attributing everything to psychiatric illness. We've had patients who have been very agitated, very aggressive, and we've with a history of mental disease, so it's been attributed to that, and we've missed major sepsis. Okay, so it's really important to understand the different presentations of mental illness, but to understand how it can cross with organic pathology. So that agitated patient, that confused, seemingly, jabbering patient, may be delirious, may be septic.
So lots of people think psychiatry isn't a real thing, like gynecology or like doing an operation to remove someone's womb or doing a heart transplant. But people can't help how they feel. People don't make themselves depressed. Psychosis, people can't help being psychotic. There's maybe a genetic predisposition to having some of these illnesses, but they are real and they need real treatment with medication, with therapy.
Variations in emotions in every patient are very real, and it can't be managed by just getting a grip on your personality and changing it. I think it's important to deal with it, be aware of it, and preempt the problems.
The fact that the patient doesn't have an underlying organicity, that the patient doesn't need surgery, that the patient doesn't need drugs, doesn't mean that the patient is not ill.
What would I say to the orthopedic surgeon? I'd say, look very, very carefully at how you manage and how you understand your patients, and that has a lot more to do with psychiatry than it does orthopedic surgery.
When I was in medical school, I was not particularly interested in psychiatry. The reason being that I thought that not too much could be done to help patients. And we all feel when we're medical students that the purpose of our job is to help patients and to cure them.
A recent case, which has been really, really rewarding, was a lady who came to me about a month ago with very severe postnatal depression, never been seen here before, and she was absolutely beside herself, hadn't slept for a few days. And after I'd seen her, we put a program in place, we called the health visitors, we started her on treatment, organised a review, and within 4 weeks she'd already started making major recovery. And yesterday I saw her again and she was sleeping well, she was feeling much better, she bonded with her baby.
People, for example, say that the hip replacement doesn't feel like it's theirs, which is a strange thing to say, but those are the typical people that you have to manage, and you might have to say something simple like, the joint will become part of you in 2 or 3 months' time. And once they've heard that and acknowledged that and they accept that, they kind of improve and they do better. And this is all about understanding and dealing with the aspects of psychiatry in its broadest terms.
The patients often get better with treatment, and it's very rewarding. So every day I'm seeing people who are recovering from depression, and they're so grateful, and it's such a rewarding area to be.
Anybody with any experience will see the impact of mental illness in many ways. I mean, just from something as simple as someone won't take their medications to someone being, presenting with life-threatening illness due to it.
Well, I think understanding mental health is relevant in any specialty.
So this is a real area with exciting treatments that are changing all the time.